So I'm Dr. Pierre Fenaux from Hôpital Saint-Louis in Paris, which is part of APHP network, and I'm head of the Department of Hematology of that APHP North part. I'm also professor at the University of Paris and chair of the French MDS group. So first, we have to say that only few mutations can be targeted in MDS, and those are the IDH1, IDH2 mutation, potentially P53 mutation, although it's not specific to MDS, and it's certainly difficult to target. Now, there are studies suggesting if we use IDH1 or IDH2 inhibitors, including in first-line treatment, including in high-risk MDS, that some significant responses can be obtained. So even if the mutated clones are not so big. And so this is really important, and the future is probably going to be the combination of those drugs with classical treatments like hypomethylating agents and potentially chemotherapy. So this is for IDH. Now, FLT3 duplication or mutation occurs very rarely in MDS, so it's not a good target. Now, regarding P53, it's a very difficult molecule to target. It's mutated in 50% of the cancers. So if it was easy to target, it would have been mutated. It would have been addressed a long time ago. So currently what we have with the reconforming agent APR-246 appears to be moderate effect in some patients, potentially allowing profound responses in some patients, allowing them to be bridged to transplant, but otherwise there's no clear advantage. So we will need other drugs to target TP3 mutation. There are some suggestions that the CD47 inhibitor magrolimab could be particularly efficacious in this subset, but we have no mechanism of action here. So is it going really to be confirmed? That's unclear. So for this, for targets in MDS, that's really a minority of patients. Now, what other emerging treatments for high-risk MDS are likely to influence clinical practice? I think it is really the combination of hypomethylating agents with other drugs. So we've had disappointment with pevonidostat. We overall have had a disappointment with APR-246. We're waiting for results of sabatolimab and of venetoclax. Venetoclax has the advantage of having shown some superiority over, azacitidine plus venetoclax over azacitidine alone. This was in AML, but of course, those two diseases are a continuum, so it's an advantage, but it has to be once again demonstrated in the phase 3 study, which is ongoing. And hopefully, if some combinations work, some double drug combinations, we hope that triplets will do even better if the third drug is not myelosuppressive. And we have to bear in mind that the median survival of high-risk MDS is still about 18 to 20 months with an HMA alone. This is very poor, with very few long-term survivors. So it's really a disease we have to improve. Well, another issue is the advent of CPX-351, which is intensive chemotherapy, but with less mucositis, and this can be important in elderly people. It may be better than 3+7. This isn't clear, but we know that chemotherapy, intensive chemotherapy overall in MDS is probably not going to be very active in patients with unfavorable karyotype, especially complex karyotype, and it will be more active in patients with favorable or normal karyotype, but probably largely as a bridge to transplant. But what we found was that it appeared to be CPX-351 appears to be an interesting bridge to transplant in MDS. And well, I think this is what we can say currently of new approaches. And as I said, magrolimab could be another one, but let's see once again what phase 3 studies tell us. Now, for AML not candidates for intensive chemotherapy, we have now a reference treatment, which is not an HMA alone, but an HMA plus venetoclax. And really the idea here is to add to this duo, I would say, drugs, especially targeted drugs like IDH inhibitors, like FLT3 inhibitors. So far, we don't have results of those triplets. We know that, for example, azacitidine plus an IDH1 inhibitor is better than an HMA alone, but this does not mean that the triplet HMA plus VEN plus IDH1 inhibitor will be better than HMA plus VEN. So we'll need those trials. The same with FLT3 inhibitors. So that's going to be very important. And of course, we have the new, more powerful FLT3 inhibitors like gilteritinib and others, which are probably better than the first generation one. But once again, phase 3 trials will be necessary to demonstrate this advantage. So we are here dealing with patients who have no specific mutations like IDH1, IDH2, and FLT3. And we know that the backbone treatment is the combination of azacitidine of decitabine and venetoclax. And how can we improve those results? Now, to improve those results, we need first drugs that are not myelosuppressive, because having 3 myelosuppressive drugs in elderly AML would be hardly feasible. And there are some drugs which have shown some interest in phase 2 trials, and especially sabatolimab, which is a TIM3 inhibitor, and also magrolimab, CD47 inhibitor, cusatuzumab, potentially also, and lastly pevonidostat, which when combined with azacitidine alone proved disappointing, but could perhaps add something to azacitidine and venetoclax. So clinical trials are ongoing or recently finished their inclusions, and we have to wait for the results. Indeed, it's very difficult to anticipate those results. We've seen disappointments with some drugs particularly in the recent years. So let's wait for the results in those patients, and potentially use, in addition to major endpoints like survival, event-free survival, other endpoints like minimal residual disease, which may help us perhaps have early surrogate endpoints for those combinations. So we're speaking of personalized treatment, personalization. I think it has several aspects. The first is, of course, you personalize on the biological characteristics of the disease, like an IDH mutation, FLT3 ITD or mutation, TP53 mutation, when you can and when you have the drugs. The second is, of course, to personalize by adapting on the patient age, comorbidities, etc. And the third is to adapt on the response to the first line treatment or to the early treatment. In particular, when you achieve complete remission, you have to assess by very precise tools like minimal residual disease if indeed the response achieved is deep or not. And flow cytometry in particular is a very interesting tool when you don't have gene rearrangements that allow you to PCR in the cells. And so it's an important tool after, in particular, non-intensive treatments, which I think will be important in the future to monitor our treatments.
Hello, I'm Esther Oliva from the Grande Ospedale Metropolitano from Reggio Calabria, Italy. And I'm a hematologist aiming at research in myelodysplastic syndromes, acute myeloid leukemias, and other anemias. So we know that TP53 gene mutations confer particularly poor outcomes. Such mutations are detected in about 20% of MDS or AML patients, and they are more frequent, up to 40%, in therapy-related cases. Target therapy includes APR-246. At the recent ASH meeting, 2 previously reported phase 2 study trials were combined in a long-term, multi-center international collaboration of the US MDS Clinical Research Consortium and the GFM. The study validates NGS clearance of mutant TP53 as a critical biomarker of allogeneic stem cell transplantation outcomes in mutant TP53 patients. Then there are other targets such as IDH mutations, and there are treatments being investigated for myelodysplastic syndromes. Ivosidenib, an oral IDH1 target, and enasidenib, an inhibitor of IDH2, both approved in the US for the treatment of patients with relapsed refractory AML, were presented at ASH as preliminary results of 2 phase 2 studies, respectively of ivosidenib and enasidenib. The responses appear to be encouraging, particularly in first-line, low and high-risk MDS patients. Of course, all these drugs need to be tested in large randomized trials to confirm the results that have been already presented at the ASH meeting. Well, sabatolimab is an immunomyeloid therapy which targets TIM3, which is expressed on immune cells and on myeloid leukemic progenitors, and not on normal hematopoietic stem cells. And at ASH, results of a phase 1b study, which combined sabatolimab with hypomethylating agents in patients with higher risk MDS, reported an overall response rate which was quite good, 57%. So this seems to be one possible promising drug. So another promising drug combination is venetoclax and hypomethylating agents. ASH reported on more than 1,000 higher-risk MDS patients treated at the Moffitt Cancer Center with revised IPSS of intermediate or higher risk, who received hypomethylating agent as a first-line therapy after diagnosis. What was interesting was that for those few patients who received first-line hypomethylating agent alone and then received hypomethylating agent combined with venetoclax for relapse or refractory MDS, the overall response rate then was 61%, and the median overall survival was 33 months from diagnosis, compared to 21 months for those who had first-line combination hypomethylating agent and venetoclax, and 20 months for those who received just first-line hypomethylating agent with no subsequent venetoclax therapy. So this may be a signal that sequential combination therapy may be of particular benefit. Another promising drug is CPX-351, which is the liposomal combination of cytarabine and daunorubicin. This was assessed in untreated high-risk MDS, aged less than 70 years. Most were candidates for allogeneic stem cell transplantation, and the response to induction treatment often had to be delayed due to prolonged cytopenia. Nonetheless, the treatment conferred a very impressive response rate with a high CR rate, and 2/3 of patients had it with an indication for stem cell transplantation was able to receive stem cell transplantation. Gilteritinib is an oral FLT3 kinase inhibitor approved for the treatment of patients with relapsed refractory FLT3 mutated AML. In a study presented at ASH, newly diagnosed older unfit patients with FLT3 mutant AML was treated with low-intensive chemotherapy plus FLT3 inhibitor versus the same but with the addition of venetoclax in a triplet regimen in clinical trials at the MD Anderson. The triplet HMA venetoclax FLT3 inhibitor was associated with better outcomes compared to the doublet. The median overall survival was not reached with the triplets and better than the doublets, which was 9.5 months. So these findings suggest the need for prospective validation of triplet therapy with HMA, venetoclax, and FLT3 inhibitors in older unfit AML. In another phase 1-2 study, patients with either refractory FLT3 mutated AML or high-risk MDS-AML, or patients with newly diagnosed FLT3 mutated AML, unsuitable for intensive chemotherapy, received azacitidine, venetoclax, and gilteritinib in 28-day cycles. In the newly diagnosed cohort, all patients responded and all achieved marrow remission by day 14. So this combination appears particularly encouraging in frontline setting where the response rate was 100%. So then there was the AGILE study, a randomized phase 3 study for patients with newly diagnosed acute myeloid leukemia harboring an IDH1 mutation, not eligible for intensive chemotherapy, randomized 1-to-1 to ivosidenib plus azacitidine versus azacitidine and placebo. Event-free survival, overall survival, and CR rates and overall response rates were highly in favor of the ivosidenib and azacitidine arm. The adverse events were similar in both groups, and so further enrollment into the study was prematurely discontinued due to the clear evidence of benefit. Well, I already mentioned the sabatolimab trial, which included 40 newly diagnosed AML cases. The other interesting combination was reported in the phase 1-2 study of azacitidine with venetoclax and magrolimab in patients with newly diagnosed unfit high-risk acute myeloid leukemia and relapse refractory AML. Patients were frontline with particularly poor prognostic factors, ven-naive or ven-exposed refractory AML. The triplet was considered safe with high CR rates, 94%, and particularly in the newly diagnosed patients, the majority of which did have adverse risk prognosis. The recovery occurred within the first cycle, so there's not cumulative neutropenia or thrombocytopenia with magrolimab. Research on the most familiar combination venetoclax and hypomethylating agents has informed on treatment personalization. We know that venetoclax combined with cytarabine or hypomethylating agents improves response and overall survival. But resistance and relapse still occur in most patients. So the identification of prognostic markers are important to guide venetoclax use. ASH reported on protein expression targets to predict overall survival and remission duration in AML patients treated with venetoclax. The protein expression of diagnostic leukemia samples of cases with AML treated with venetoclax, most in combination, were assessed and 44 proteins were identified. In this protein signature, SPI1 and Notch1 and PTPN12 could predict clustering with a computed accuracy of 94% to distinguish patients that would have a better overall survival, better remission rate, and duration. So protein expression signatures, which do need validation, might enter the computation for prediction of response and survival and guide treatment selection, like indicating alternate therapies for high-risk patients, including transplant and first complete remission. Many new targets for combination therapy to prevent venetoclax resistance were also identified and need to be tested in the laboratory for clinical relevance. Now, in treatment-naive AML with intermediate and poor risk cytogenetics, with or without TP53 mutation, the venetoclax hypomethylating agent combination was also assessed. And in patients with TP53 mutant AML, the response rates were in favor of the combination, but these did not translate into improved duration of remission or overall survival. In the TP53 wild type cases, the combination treatment was associated with higher remission rates, prolonged duration of remission, and a better overall survival compared to patients treated with ADS alone, and definitely indicates combination treatment in such patients.
Hello, my name is Dr. Andrew Way. I'm from the Alfred Hospital in Melbourne, Australia. At this year's ASH, we had some really interesting presentations on targeted therapies. So the first one was with APR-246. This was the great hope for P53 mutant disease with really high response rates in this really difficult condition. However, the randomized study, we have had early feedback that that study was negative with respect to the primary endpoint, which was true CR. And so clearly APR-246 would need to be examined in future directions, perhaps in combination with venetoclax azacitidine, which there is a study currently ongoing. There was also interesting data presented by the GFM group with respect to the role of targeting IDH 1 and 2 in high-risk MDS. And I thought these two presentations were very interesting because of the higher responses observed with single-agent IDH inhibitors, and clearly tolerability is going to be very good, and the patients can just take an oral medication. This is a really difficult subgroup of patients to do trials on because IDH mutations are quite rare in MDS, perhaps individually making up about 5% of the MDS population. And so the GFM groups to be commended on doing these studies. What we don't know is whether azacitidine versus an IDH inhibitor, which one would be better in terms of longer-term efficacy, because no randomized studies have been done. And again, obviously very difficult because of the rarity of the disease, or whether combining IDH inhibitors with azacitidine will be the way to go. But clearly, this is a great start. At this year's ASH, there were also additional presentations looking at other combination therapies in high-risk MDS, including sabatolimab, a TIM3 inhibitor, as well as venetoclax in combination with azacitidine. And both of these treatment options are different. One is more myelosuppressive with respect to targeting BCL2, and with sabatolimab, this is also very interesting, but the mechanism of action of sabatolimab remains unclear, and also the response rate with sabatolimab plus azacitidine appears lower than what's been observed with venetoclax plus azacitidine. However, the tolerability of the regimen definitely appears more favorable. What is clear, however, is that venetoclax plus azacitidine and also other treatments such as CPX-351, which was presented at this year's ASH, both of these approaches can produce very high response rates in MDS. And this is a really important aspect in terms of taking people to transplant. And so I think it's really going to be interesting to see whether one or both of these regimens becomes a pathway to transplant for high-risk patients with MDS, who are invariably the younger patients. Mikhail Sekharis also presented data on pevonedistat in combination with azacitidine in the Panther study, and unfortunately this was a negative result. And so we're not sure where pevonedistat's going to go in the future. Again, trials are being done in combination with Ven/Aza, but it would definitely seem that we need to look at what is the best response rate in MDS, and whether perhaps alternative endpoints such as event-free survival, which measures not just the CR rate, but the durability of response, might be more appropriate for these difficult pivotal studies in MDS. There were some interesting abstracts presented at this year's ASH, particularly in terms of the role of targeting FLT3 in older unfit patients with AML, and also targeting IDH1 mutation. With respect to targeting FLT3, this is an important objective because venetoclax plus azacitidine produces a good response rate in patients with FLT3 ITD mutation. However, survival doesn't appear to be prolonged with venasa, and that's because emergence of FLT3 mutant clones appears to be a key resistance mechanism. And so the great hope was that gilteritinib, which has been approved for relapsed refractory AML, might demonstrate promising efficacy in combination with azacitidine in the frontline setting for older unfit patients. However, this study result called LACEWING was unfortunately negative, and it would seem that gilteritinib in combination with azacitidine didn't improve event-free survival. It did improve early responses, but clearly event-free and overall survival were not improved by this combination. It was noted, however, that about 20% of patients in the control azacitidine arm, once patients went off study, went on subsequently to other FLT3 inhibitors. And so this could be a confounding issue for the trial. The other important trial was Agile, which was presented by Professor Doner. And this is a really important practice-changing trial where the IDH1 inhibitor ivosidenib in combination with azacitidine was compared to placebo plus azacitidine. I think we were all stunned by the result of this trial. It was resoundingly positive for the primary endpoint of event-free survival, but more importantly, overall survival was dramatically improved by the addition of ivosidenib to azacitidine in patients with IDH1 mutant AML. Response rate was also improved. And so the other important aspect was the rate of infection is lower, appears to be lower than what we experience with venasa. So the key question for the future is, what is now the new standard of care for IDH1 mutant AML, venasa or ivosidenib-aza? And I think that will be the discussion points which people will be focused on over the next 6 to 12 months. In terms of new agents for the future in older patients with AML, two studies which were quite interesting. Well, one was presented by Naval Dava, which is looking at the possibility of triplet therapy using venasa as a base, but adding the CD47 targeting drug magrolimab. What was really impressive about this triplet combination was that the response rates observed were extraordinary, I think with a true CR rate of around 80%, compared to 37%, which was reported for venasa in the Viali-A trial. Obviously, the experience is still really small. Survival follow-up is very short, but incredibly promising data. And this triplet combination is now going forward into a phase 3 study called Enhance-3. And I think the major learning point from this trial was that adding an immunotherapy on top of venasa is very tolerable and certainly can produce very important and promising increases in early efficacy. Another study which was presented trying to emulate this line of testing is using cusatuzumab, which is an anti-CD70 antibody in combination with venasa. This was presented by Gail Rabose this year at ASH, and again showing very early promise with very good response rates, but not much in terms of survival because of the short follow-up. And so both of these regimens are obviously being optimized for phase 3 development, and it just shows the rapid progress in AML, where 10 years ago we had nothing, and now we're talking about triplet therapies with response rates pushing 70 to 80% and substantial improvements in two-year survival. In terms of using molecular information to guide practice, one interesting presentation was by Dan Pollier, who presented the results of Venasa, separated according to whether patients had poor cytogenetic risk or intermediate cytogenetic risk. We know that Venasa produces excellent response rates of 66% in AML. However, Dan's presentation also illustrated that in adverse risk patients, if you divide this group into those with P53 mutation or not, that patients without a P53 mutation but adverse cytogenetic risk appear to have responses and survival outcomes which are very similar to non-adverse patients. And I think this is really important information, because we know that P53 mutant patients perhaps don't have a clear improvement in overall survival with Venasa. But what this new presentation shows us, that adverse cytogenetic risk patients without P53 mutation can actually do incredibly well. And so I think this substratifies poor cytogenetic risk into those with or without P53 mutation for future studies, and improvements obviously needed in those with P53 mutant abnormalities.